And we have Dr. Abhishek Srivastava, who is a chief endocrinologist from Jabalpur, Madhya Pradesh.
Thank you, Anushri, and thanks. Hello. Yeah. Uh, Thanks to organizer for inviting us and giving this opportunity to chair this session. So I will invite our first speaker. We are already running late, and our speaker is Dr. N.K. Singh. He is a diabetologist physician in Dhanbad, from Dhanbad, and he has lot of accolades to his credit, and we are running short of time, so we will start as soon as possible. Yeah, Dr. M.K. Singh.
Good evening. I think it is really too late, but I will try to finish as early as possible. Thank you, chairpersons. Thank you, Diabetes India, for giving this very unique topic, that is unleashing the potential for renal protection with SGL2 inhibitors. What are the clinical perspectives? कहाँ से जा रहा है यार? Change नहीं हो रही देखो. Yeah. So my agenda is, when you give SGL2 inhibitors to the hearts of untreated diabetics, lots of things you know that is going to happen. What is happening with the kidneys if you are giving the SGL2 inhibitors? Is it the same? That is to settle the agenda today. Today we are in the 2022, and the great leap forward is there. Initial concerns about the SGL2 inhibitors that was focused on possible detrimental effects on the renal system, particularly to increase genitourinary infections, compromise bladder health, and aggravate acute kidney injury. That my worry in our mind that has eased today in this 2022. And the apprehension with this drug molecule, that if you give the SGL2 inhibitors that cause a temporary dip in EGFR and cause a persistent reduction in plasma volume and blood pressure, that has again taken a positive shape. So again, this is something very unique is happening in diabetology. And cardiovascular outcomes trials and the real world studies have identified the potential advantageous effect of these molecules to reduce the risk of onset and progression of several cardiovascular conditions and to preserve kidney functions. So my vision is that we have a great leap forward with this molecule, and as you know that this molecule comes from this florogene that is isolated from apples, and you are well aware that an apple a day, today we can say more precisely an analog of a chemical in the bark of an apple tree, that you give SGL2 inhibitors to a patient in case the heart failure and kidney failure away. So this is again a very important message. Now in short, what is the relation of diabetes and kidney? Rishta kya hai? So over the last 2 decades, at variance with this cardiovascular morbidity and mortality, which has progressively declined in patients with diabetes over the last 2 decades, the trend in microvascular complication has remained substantially unchanged. So आप दवा देते जा रहे हो, लेकिन microvascular complications they have not changed. This is unchanged. So in particular, this DKD, the diabetic kidney disease, that accounts for 60% of new patients beginning renal replacement therapy. This is worldwide data. And its prevalence has shown only a slight reduction in the recent years. And even if you give with the Indian study, which like this study of ICKD study, we have a huge problem with diabetics, with diabetic kidney disease and CKD. So one of the most common these complications of diabetes is very important is CKD and DKD. And as I told you, this is the leading cause of ESRD, that is accounts for 45% of all causes. So DKD is a major contributor to CKD and ESRD, and it also portends worse outcomes within a 5-year survival rate of less than 40% if the patient has got ESRD. So this DKD has been shown to be a large contributor to the excess risk for all cause and cardiovascular disease mortality amongst type 2 patients. So this is a scenario. So the greatest increase in this prevalence has occurred even in the low to middle income countries like India. So incidence of cardiovascular disease in patients with type 2 diabetes has improved. That is very important things has happened. But this effect has not been associated with any substantial reduction in type 2 diabetic patient associated renal impairment. So this is a crux of the problem today. And what is happening? So today you have got the RAS blockade and has been the last successful drug class for your GFR preservation, independent of the effect on the blood pressure. And you are well aware of all the renal trial and this IDNT trials that showed that losartan and irbesartan, they reduced this composite kidney endpoints around in the tune of 15 to 20%. But unfortunately, this disease, the diabetic kidney subjects, and you are giving the RAS blockade, still progress to the kidney failure and at a very significant pace. So this is the problem. And so nephrologists today feel that what we are going to do, that we are trying to using these daggers to fight the fire, breathing dragon with this dragon, this is dragon, diabetic kidney disease, and our weapon is so weak. So today the CVOT has showed that these agents may fit this bill, the canvas and empiric, not only showed CV protection, but well aware, you are aware that also kidney endpoints. So while advances had been made in the treatment of various glomerulonephropathies, the mantra for DKD seemed to be fixed on the time-tested but erect principles of the managing any kidney disease, namely the blood pressure control, proteinuria reduction, and we have got definitely the ACE inhibitors in ARB. But this approach has been unsatisfactory and high rate of kidney failure and death is occurring. So what to do? So what next? So it is important to remember that the majority of our patients, more than 80%, in the early SGLT2 trials were on the ACE inhibitors or ARB and all the patients. And in credence, we are on maximally tolerated dose of the ARB and ARBs. So CKD inhibitors work in patients with DKD or RAS blockade, which produces efferent vasoconstriction, but the crucial question still remains. And so today, it is time to change the terminology of this group of molecules, that is, it is a cardioprotective drug and the nephroprotective drug, and I say it is a new nectar in the diabetes. And I'm not going to tell you all the details of the effects, but in 2 slides, let us see what is happening. What is happening in the DKD? There is persistent hyperglycemia, upregulates the glucose reabsorption, and secondarily, sodium and chloride reabsorption in the proximal tubules. We are well aware. And this decreases sodium and chloride delivery to the macula densa, which is mistaken for the decreased kidney perfusion. This results in decreased adenosine production and a decrease in afferent arterial tone, increasing blood flow to the glomerular signal. So this is happening. But if you are using SGLT2 inhibitors in such cases, the glucose reabsorption is blocked in the proximal tubule. This increases sodium delivery to the thick ascending lip of the loop of Henle. This increases the activity of the sodium potassium chloride co-transporters as energy requiring process where adenosine triphosphate is broken down to adenosine, and increased adenosine, this acts in paracrine manner on the afferent arteriole smooth muscle cells and leads to afferent arteriole vasoconstriction, decreasing this blood flow to the glomerulus. So this afferent vasoconstriction combines synergistically with the efferent vasodilatation produced by the RAS blockade to reduce the intraglomerular pressure and glomerular filtration. So things are just changing. So when patients are using these SGLT2 inhibitors, in such cases, the whole process is reversed. Inflammation decreasing, fibrosis decreasing, the oxygen consumption is decreasing, hypoxia is also decreasing, and alteration in energy metabolism is changing, and so we are getting the cardio protection and also this kidney protection. So like this is like a Hunt's remedy, which never fails. And SGLT2 inhibitors increase also the erythropoiesis and may improve the anemia in patients with CKD and HREF. So this is again an important slide showing that the kidney body is as a direct modulator of intracellular nutrient signals is talk of 2022. So in diabetes happening renal mTOR C1 hyperactivation, and if you are giving the SGLT2 inhibitors, the ketone body is increasing, so leading to this altered intracellular nutrient signals, this hyperactivation of the mechanistic target of this mTOR C1, and strongly associated with the both this proximal tubular epithelial cell and podocyte damage which is happening, that decreases the inhibition of overactive this mTOR C and signaling and represent a therapy for non-protonic and protonic DKD. So this is what is happening. So there are lots of renal and extrarenal mechanism of actions of happening. Renal you are showing here, and the extrarenals I'm not going to repeat it. So ultimately with all these mechanisms of action and clinical effects, renal protection is happening. Next part is what is the data today we have. In 2020 this that stands the test of time. How this renal protection by SGLT2 inhibitor happening. So we have data from the CVOTs and we have data also from the renal trials. And all starts with this, as you know, the EMPA-REG outcomes. And EMPA consistently, where we consistently showed EMPA-REG that the rate of eGFR decline across all kidney risk categories. This is quite evident here from the cartoon. So this resulted in regression of albuminuria status in patients with type 2 diabetes and prior albuminuria from the EMPA-REG outcome. And solid kidney outcomes using different definitions of substantial loss of kidney function with EMPA-REG, CANVAS, and declared TIMI or VertiCB, you can see what is happening with the HR. So this is just really very, very impressive. But the first landmark trial that highlights the power of SGLT inhibitors, I say, was the CREDENCE. And this was a silver lining in the dark cloud of the diabetic nephropathy. And the conclusion of CREDENCE trial are certainly exciting for us managing DKD and CANA with significant benefits in both renal and cardiovascular outcomes even in individuals with more advanced CKD. They used the more advanced CKD, and the fact that this benefit is observed even on a background of maximal ACE or ARB was very encouraging. So I'm not going details of that. This CREDENCE trial is very important, showing all the key renal and CV outcomes which favor this CANA. But later on, more good news came and from the CREDENCE, and that was the DAPA CKD, Emperor reduced, Emperor preserved, VertiCB, and now the EMPA kidney. So these are very, very landmark trials which have shown. And ultimately, if you see the kidney outcomes using generally consistent definitions, even the pooled estimates, that all favors the SGLT2 inhibitors these days. And if you see that this confers the meaningful kidney benefits, regardless of the even the patient is diabetic or non-diabetic.
Sorry, excuse me.
2 minutes.
Yeah.
Yeah, I'm just finishing. And we have got the Emperor reduced study, which also giving the same message, and this low, even this will be well shown here. And if you go with EMPA, I'm not escape this slide. So you see here also from the Emperor preserved, the summary of key results is again favoring all the key secondary endpoints in favor of SGLT2 inhibitors. And this, so EMPA protects the kidney by significantly slowing the decline in kidney function. And there a catalyzed change came with the deep DAPA CKD, giving the same message that reduce the risk of kidney failure, reduce the risk of CV death or heart failure, hospitalization, and prolonged survival. And so later on, this shows very that there was a significant victory with the without diabetes also. And then there came this EMPA kidney, which is the third major trial of an agent which tested in patients with CKD to be stopped early because of positive results that made a pre-specified things. So there are lots of this side again important, that the EMPA kidney expands the scope of types of patients with CKD which we are using in our clinical practice. And CREDENCE tested CANA only in patients with type 2 diabetes and diabetic nephropathy. But DAPA CKD, 2/3 of enrolled patients had type 2 diabetes and all had CKD. And EMPA kidney, 46 patients of the 6609 enrolled patients had diabetes, including a very small number with type 1 diabetes. And another departure was very significant, that the EMPA kidney, 20% of patients did not have albuminuria. So this gives again a very, very important thing in the field of this nephrology with diabetes and also. So EMPA kidney is very, very important trial. I'm not going to details of the trial, but you can see here, this is a reflective of the CKD population globally, where the majority of the patients do not have severely increased albuminuria. 50 to 70% of CKD patients do not have type 2 diabetes also. So this is a very, very important message coming from the EMPA. There are lots of real world studies. This shows how the flow, what is happening next. With this flow or another remodel trial all will come, but message from DIAD 19, I will not go in detail, but it is also giving very safety signals of the DAPA in the COVID cases also. So lastly, the big picture which is emerging with the SGLT2 inhibitors, that the slowing in the eGFR decline by 0.5 to 1 ml per minute predicts long-term risk reduction of the CKD events. You can see, and this again, this is shown after this canvas reduction of eGFR decline. So average patient would develop eGFR by over 15 years. This is one calculation. Dr. A.K. Singh is here. He will say whether this calculation is valid or not, but this is also from the NEGM, that 15 years you get if you use this. Lastly, this very important point that the SGLT, if you are using the SGLT inhibitor and GLP-1RA, there is lower risk of MACE in those with atherosclerotic cardiovascular disease, but this only SGLT inhibitors exert improve HHF and kidney disease progression. So somewhere it is scoring over that, I think. And also the guidelines are quite clear with the ADA KDIGO guidelines. Even the eGFR more than 25, you can use it. So let's go in details of that. Just concluding my talk, the final points are that in the 2022 therapies are effective down to eGFR of 25. It is critical for cardio kidney metabolic physicians to discard the old obsolete eGFR threshold of 45 or 60 that were based on glycemic factors rather than heart or kidney protection. So this is a crystal ball SGLT2 genomics where you can use it, and don't go, the SGLT2 inhibitors are an important weapon in our arsenal against not only type 2 diabetes, but also the conditions that we encounter that go in hand in hand, including the CKD and the cardiovascular disease. Lastly, the frontline clinicians should initiate SGLT inhibitors for patients with type 2 diabetes and diabetic kidney disease who have an eGFR of at least 30. So you must start it. And differing initiation of SGLT inhibitors to a specialist, you are suffering that you are going to a nephrologist or endocrinologist, that will result in a faster progression of diabetic kidney disease, irrespective of the glycemic control, and it is crucial to initiate these medications as early as possible. And prescribers should be aware of the initial reversible drop in eGFR of approximately 5 to 8 ml. That will happen, but in the next first 2 weeks after starting this molecule, which is due to hemodynamic effect of the drug. So using SGLT2 inhibitors can slow the decline in eGFR, reduce the onset of micronuria, and slowly reverse the progression of proteinuria. Thank you very much.
Thank you very much. Yeah.
Thank you.
So you concluded well in time.
Yeah.
Thank you very much. And now we'll invite our speaker. And if there is any question, we will take at the end. So I invite Dr. Puneet Saxena. He is a very well-known figure in the field of diabetes. He is from Jaipur, and he will be taking over the next lecture.
बोले तो
Good evening, everybody. And I've been given this task of speaking on paradoxes in diabetes. And there have been many in the past which have been resolved by observations in science, and there have been going on. Every day there is something has been observed, and it is classified as paradox which does not match the notion or the popular belief. and it doesn't fall in line with the guidelines that falls into the category of paradoxes in diabetes. And I am going to discuss few. There may be many more, and many more may come up with passage of time. But so I always start with the some part of epidemiology, just to stress upon that we are discussing something very important. So diabetes, one of the top killers, first 10 causes of death globally, and it increases the risk by 2 to 3-fold. And so every deliberation and every talk on diabetes makes it more important that what we are discussing. So hyperglycemia is the manifestation, and you can say the primary biomarker, but there is a disturbance of carbohydrate, fat, and protein metabolism which is underlying, and which gives rise to the paradoxes. And there are certain paradoxes which I am going to discuss today. The first one is the paradox of diabetes and obesity. What is that? So despite the role of obesity in development of chronic comorbidities, once these conditions are manifested, being overweight may provide some protection. So this is providing protection rather than being adverse. So this has been termed the obesity paradox, and it's based on the observation that obese patients with cardiovascular disease survive longer than their normal weight counterparts with cardiovascular disease. And studies have shown that individuals with established CVD and heart failure with moderate degrees of obesity present a more favorable prognosis than those who are normal or underweight. So our common belief is that the obese people will suffer more in terms of morbidity and mortality, but it is not like that. And why it is so? Obesity has been called the mother of all diseases, and is strongly linked to diabetes, and mainly its abdominal form is considered the major risk factor for not only type 2 diabetes but for lipid disorders, hypertension, coronary heart disease, and certain cancers also. And if you see that for characterization of relative risk of mortality and morbidity, the rates in underweight, overweight, class 1 obesity, class 2 obesity, and class 3 obesity are compared with those in normal weight subjects to understand that why obesity and what obesity is causing in diabetes. So the common belief is that mortality increases as BMI increases above 25, and as the BMI decreases below 25, there is a survival benefit. But during the past decade, rather not a past decade, it was more than 2 decades, there is an increasing evidence that the patients, especially the elderly, with several chronic diseases and elevated BMI may demonstrate lower all-cause and cardiovascular mortality compared with the patients of normal weight. And the association of diabetic complications with obesity has consistently shown paradoxical results. And in people with diabetes with a higher body mass index up to class 1, please note that it's up to class 1, obesity seems to have a protective effect. It's only class 2, class 3 and above that the diabetics face worse outcomes, but up to 1, it's in favor. So in patient with type 2 diabetes and cardiovascular comorbidity, overweight and obese patients, lower mortality compared with normal weighted subjects have been seen. And not only this, weight loss and not weight gain was associated with increased morbidity and mortality during the mean follow-up of 34 months in one of the studies. So normally what we are advising to our patients is go for weight loss. But what has been seen in this study is that weight loss is creating more problems. And not only this, amputation risk decreased in diabetic men with increasing BMI. High mortality rates were observed in hemodialysis patients who were diabetic, suffering from end-stage renal disease because of diabetes. And those who exhibited lower BMI and weight loss, they fared worse than the people, those who were obese. And a partial explanation was given was that there is a lower BMI weight, the obese people, they have lesser muscle mass and therefore they have lower creatinine levels for their body mass index. See, another meta-cell is from Scotland. Almost 30,000 overweight and obese patients were studied of type 2 diabetes in terms of cardiovascular complication, and it was concluded that within patients with BMI up to 40, there was no difference in the incidence of all-cause mortality, myocardial infarction, congestive heart failure, even peripheral vascular disease and cerebrovascular disease. So even up to 40, no difference between the lean and the obese. And only when the BMI was more than 40, an increase in incidence of all-cause mortality and congestive heart failure and other complications was seen. And the current belief in the scientific community is that obesity induces insulin resistance, and which is true, which is proved more, and hence is causally related to onset of diabetes. But subsequent development of chronicity with diabetes seem to lead to same adiposity becoming protective also. So this again is a paradox, that while the incidence of diabetes is increasing with obesity, the incidence of complications is decreasing, or not decreasing, is not that high as compared to the normal or underweighted people. So another factor that needs to be considered is that not all obese patients are going to develop diabetes, not all. And adipose tissue expansion is an active phenomenon at the onset of diabetes, but seems to confer protection from the development of diabetic complications as the disease starts to be chronic. An increase in the amount of fat stored in adipocytes alters their metabolism and energy homeostasis. There have been explanations for this paradox. Fewer free fatty acids are cleared from circulation and more free fatty acids are released into circulation from adipose tissue as its capacity to store triglycerides is saturated. And moreover, obesity has shown that there is expansion of beta cell mass in rats as well as in some of the human studies. And there have been other mechanisms and postulations to explain increased survival in people with higher BMI and chronic complication of diabetes, and that includes secretion of soluble TNF alpha receptors and lipoproteins from adipocyte tissues. Few more studies. There have been growing evidence for obesity paradox, and one of these studies almost 1 lakh patients concluded that in patients hospitalized with principal diagnosis of diabetes and its complications, obese patients had a significantly lower mortality rate. Hence, there seems to be a growing evidence for obesity paradox, and this was published in 2020 in Diabetes, so not very old also. And you can see this very interesting figure now, right? So on the left hand side you can see the blue one is the underweight, and on the right hand side is the morbidly or the obese class 1 to 3, but that is BMI more than 30. The topmost line is showing you that the mean blood glucose is increasing as the body weight is increasing, but the second line shows you that the overall mortality is consistently going down as the person is getting obese. And the third line is that the incidence of hypoglycemia is lesser in the obese people. And probably there was a postulation that probably this less incidence of hypoglycemia is also contributing to lesser morbidity and mortality in the obese people as compared to the lean ones. And this is a list of studies which have studied the association between BMI and mortality in diabetes with a follow-up of almost 4 years. And what have they shown? That obesity paradox most likely represents a non-causal association between higher BMI and mortality in diabetes. Obesity we are calculating by BMI, and BMI is not the true indicator. And you can see here, who would you consider more obese? The person on the left, the BMI of 35 but too much of muscle mass, and the person on the right with the same BMI but the different waist circumference, and probably the amount of adipose tissue is different. So probably in all of these studies they have considered BMI and not the waist circumference or the amount of or the quantification of adipose tissue. Then fitness also plays a role. So effect of fitness on association between BMI and mortality among patients with diabetes. Very, very good slide. If you see here in the lean patients on the left hand side, what is happening? The mortality is higher. Then between 25 and 29 BMI, which is just overweight, the mortality is lesser. But as you come above the BMI 30, then mortality is further reduced in type 2 diabetics. And if these patients are doing good exercise, which is shown by the blue bars, in each respective category you see that the benefit which is achieved is maximum in the obese patients. So lower mortality risk with higher fitness level regardless of BMI, but the maximum benefit conferred is in the obese group. So again a paradox. So what is the reason? Is the obesity paradox for diabetes simply bad statistics? Because there have been limitations of all these epidemiological studies which have studied reverse causation. The confounding factors have not been matched, balanced, or excluded. There is a selection and the survival bias, there is a treatment bias, there is a one-time management of weight, and then there are limitations of BMI because body composition is not studied. the body fat distribution is not taken into account, and the cardiorespiratory fitness, which definitely plays a role, is not being accounted. So there was another study, and it has come in 22 only. So normal weight people with diabetes have more emergency room visits, inpatient and office-based physician visits than do obese diabetics. But study did not find an obesity paradox in any of the 6 measures once smokers and persons ever diagnosed with cancer or cardiovascular disease were excluded. So in this study, the confounding factors and the other risk factors were excluded. And once they were excluded, then the obesity paradox was not seen. And thereby, the recommendation of this study was that physicians should continue to focus on efforts to prevent obesity in people with diabetes.
Sir, last 2 minutes.
Yeah, I am going to conclude. So there is a term which is metabolically healthy obesity and unhealthy obesity. And on the left-hand side, you can see here that if you are metabolically healthy obesity, then the subcutaneous fat is more, the insulin sensitivity is there, the systemic inflammation is not there, the adipokines are favorable, where the adiponectin is low, the leptin is high. On the right-hand side, you can see the metabolically unhealthy obesity, where the visceral fat is higher, the adipokines are unfavorable, and this kind of obesity is going to pose risk for type 2 diabetes and CVD. So another study which was look-ahead study, it refuted that there is a obesity paradox. So I have to rush. So not associate, there is another paradox, that what happens to the critically ill patients of diabetes. So diabetes is not independently associated with mortality in critically ill patients, which we think otherwise, that all the critically ill patients, if they are diabetic, they will have worse outcomes, but it has been shown by a few papers that it is not so in all the patients. So there is another paradox which is called a salt paradox in diabetics. What is that? That the impact of dietary salt intake on GFR and the glomerular capillary pressure is altered in diabetics. And how it is so? It has been observed that the typical relationship between the salt intake and GFR is disturbed in individuals with diabetes and animals with experimental hyperglycemia. And the anomaly has been explained because the proximal salt reabsorption appears to be more sensitive to the inhibition by dietary salt loading in setting of diabetes than those without it. And therefore, the diabetics, even if they are consuming high dietary salt, then their GFR is getting reduced rather than being increased. The another paradox is the stress cardiomyopathy or taxonomic cardiomyopathy, which is a stress cardiomyopathy which happens, we see in younger people who are stressed or who are emotional or who are having hypertension surge or sympathetic overdrives. The temporary there is cardiomyopathy and there is a stunned myocardium and they will end up into heart failure. So diabetics won't have that stress cardiomyopathy. And why? Because the sympathetic nervous system or the autonomic nervous system is damaged, and the sympathetic or the catecholamine surge which comes in a normal person may not be there in the diabetics, and that's why it acts as a savior. Then there is another paradox, which is the treatment of the benefit paradox of cardiovascular and kidney comorbidities, and which is just an observation. It's an observation that the people.
Sir, can you conclude?
Yeah, this is the second last slide. Yeah.
Okay.
So the people who or the diabetics who are having cardiovascular disease, heart failure, and nephropathy, and who are eligible for GLP-1 and SGLT2, which my previous speaker was saying, they are less likely to start these drugs because they are terminally ill, they have lost hope, and the cost of treatment is such high. So this has been an observation. So something on bone mineral density and fracture. So despite normal bone density in diabetics, the incidence of fractures is higher. And all these the measurement tools like the DEXA scan and all, they are misleading in diabetes, and this again is a paradox. And something from the incidence or the prevalence of the diabetes, then there again a paradox. In the National Family Health Survey, fourth Family Health Survey, which was done in 2014 and 15, it was seen that the distribution of diabetes in India is not explainable according to the socioeconomic and the other factors, and it needs further study as pertaining to the ethnic phenotype, genetic factors, and probably other factors like the elevation from the sea level and other things like that. So this again was the paradox. So the conclusion is that the findings of obesity paradox should not change the current clinical advice regarding the importance of weight reduction in patients with type 2 diabetes who are overweight or obese. We should not recommend that patients with chronic diseases gain weight, and paradox of diabetes like regional differences of prevalence, less mortality in critically ill patients with diabetes needs further research. Thank you very much for your patience.
Thank you very much. And now we
हाँ
will
सर,
invite
he is
our
talking.
next speaker, Dr. S.V. Madhu. Dr. Madhu is a very well-known figure in the field of diabetes, and he has been actively practicing for last 35 years, and we have seen him in all the conferences. And I will not add much as we are already running having shortage of time, so we will ask him to proceed with his proceedings.
Thank you, Chairperson, and I thank the organizers of this conference for inviting me to share some of my work. I had proposed, yeah, I think that's the slide we are all waiting for. So the right slide has come.
Showing for last half an hour.
I know, but we are persisting with, okay. Okay, see, the idea of this talk, actually this talk is based on 20 years of work, so I'll not bore you with all that now. We are all waiting for dinner. The fact that we are predisposed to atherogenic disease or atherosclerotic disease or cardiovascular disease in our country as a whole, and particularly our diabetics, led us to do research in certain areas trying to understand why this happens in our country. And over the last 15-20 years, certain type of data which led to newer perspectives which I thought I could share. So what I'll do actually would be to run through in a fast forward mode. Yeah, and this is what I proposed actually to do. The first section was all our work on postprandial hypertriglyceridemia and how it affects atherogenesis in the type 2 diabetic in our country. Second was testosterone deficiency and CV risk. We've heard about testosterone deficiency earlier in this session in the context of hypogonadism, sexual dysfunction, and so on. But a perspective with regard to CV risk was another angle which I thought I will project. A recent biomarker, which is basically a monocyte CD36 marker for atherosclerotic burden and type 2 diabetes, was another area I thought I'll touch upon. Age, rage, and diabetic macrovascular disease, which means we all know that the advanced glycated end products, the receptor for the same, and the genetic polymorphisms in these could be good markers and help us also understand macrovascular disease in diabetic patients. That was a third. And the last, which we're actually coming up just now and it's yet unpublished, is bone alkaline phosphatase and atherosclerosis. We all think about bone alkaline phosphatase in the context of osteoporosis, bone turnover, and so on. But there is a link between this and cardiovascular risk because it leads to a vascular calcification. It's associated with vascular calcification that also affects cardiovascular risk and mortality. So these are certain areas where I thought I would, what I will do actually is summarize the whole thing. This is all we know. We know the traditional risk factors. And what I'll do is just go to the summary slide. This was an emerging cardiovascular risk factor in the early 2000s. And this is when we got interested into it and showed that in diabetics and in pre-diabetics, especially with macrovascular disease, we had elevated postprandial triglyceridemia, and it was graded from NGT to pre-diabetes to diabetes in large cohorts of nearly 200 patients, was associated with endothelial dysfunction and other surrogates of CVD or macrovascular disease in diabetics, published recently, and also was associated in pre-diabetes with endothelial dysfunction, especially if they had a family history of diabetics. So just the sum and substance of all these studies with respect to postprandial triglyceridemia and cardiovascular risk was that pre-diabetic subjects, no, this is not the conclusion. The next slide, yeah, these studies actually indicate that patients of diabetes, particularly in India, based on all the studies that we did, have significant abnormalities of PPTG metabolism as well as postprandial endothelial dysfunction. The endothelial dysfunction tends to worsen in the postprandial state in every patient, particularly in those who are pre-diabetic or diabetic. And therefore, the cardiovascular risk that emerges in pre-diabetics and diabetics is far more than in patients with NGT, and therefore, this could be a significant contributor to severe risk among Indians with glucose intolerance of any degree. That's one section. The second section is hypogonadism, and we heard some time back that a third of men with type 2 diabetes actually have low levels of testosterone. While this can also be associated with ED and sexual dysfunction and all the other comorbid conditions and psychosocial impacts, it also strangely or coincidentally is associated with cardiovascular risk, because we know that this is the slide which tells you why it is important even from a cardiovascular perspective. Patients with type 2 diabetes and CAD, the presence of a low testosterone showed doubling the risk of cardiovascular mortality in 19 months. That means those patients who had CAD and also had a low testosterone actually twice the number of such patients, diabetics, died in 19 months. So that's an important connotation. And a recent prospective study in elderly men also showed that there was a 1.4 times higher risk of the overall mortality in higher tertiles of or higher quartiles of testosterone among patients of diabetes and CVD particular. In LDL receptor deficient mice models also, testosterone administration reduced atherosclerosis. So it seemed to have some anti-inflammatory effect. Therefore, testosterone deficiency in general, apart from its own direct effects, seems to have enhanced cardiovascular risk, particularly in diabetic patients. And this study actually shows that the CRP and has been shown to be significantly higher in type 2 diabetes patients with hypogonadotropic hypogonadism. Therefore, a higher inflammatory state or a pro-inflammatory state, nearly double compared to those who don't have this condition, and therefore again, this probably contributes to the higher risk of cardiovascular disease. And we did a study comparing the same, which is published in IJEM, not go through it in detail. What we actually found, that testosterone deficiency is found in significant proportion, again close to 30-35% as reported elsewhere, and low testosterone levels could contribute to a significantly higher severe risk in Indian subjects, because we found it to be lower in those with macrovascular disease. Now coming to the third aspect, again quickly run over this and focus on the last aspect. Monocyte CD36 expression is associated with atherosclerotic burden in a diabetic patient. What do we mean? What is monocyte CD36 at all? It is a potential non-invasive tool to detect atherosclerosis in patients with type 2 diabetes mellitus. It is a class 2 scavenger molecule, receptor expressed in monocytes, and its role is actually to scavenge oxidized low density lipoprotein, and not scavenge but increase its uptake into the cell and cause foam cell transformation, which we know is associated with atherosclerosis. Therefore, if you were to do a flow cytometric expression of CD36, you would find that you could find abnormalities which could mark for cardiovascular risk. We studied 70 patients and showed basically that the expression of this CD in the monocytes was much more, and particularly in those in whom the A by B was also negative. So we all know that ankle breaker index is used as a marker or detecting early atherosclerosis in a type 2 diabetic patient particularly, but even in those in whom the A by I was negative or was non-conclusive, even there we found that CD expression or CD36 expression could actually detect several of these patients with cardiovascular disease. Therefore, we believed, based on this study, that MCD36 plays an important role in atherogenesis. With reference to ABI, it performed robustly as a marker of ATH, because wherever ABI was positive, this was also positive. Furthermore, it could stratify subjects within the ABI uncompromised group, that means ABI negative group, commensurate with the conventional clinical pathological atherosclerosis. That means it could be used as a marker to stratify patients with cardiovascular risk and could in the future turn out to be a good biomarker. This stat I'll totally skip. Just to say that polymorphisms and expression of RAGE gene in diabetes mellitus are associated with elevated AGE levels and macrovascular complications, and therefore even genetic markers could be used to identify and understand cardiovascular risk in diabetic patients. I think that would be enough. This area I'll touch about 2-3 minutes before we close. This was a recent observation last 2-3 years, and many of you might have observed in your clinics as well, that some of our patients of type 2 diabetes tend to have higher levels of alkaline phosphatase for no apparent reason, and their liver functions would be normal, and they would not have any bone problem as such. So when we looked at our electronic records, I seem to observe that a large, maybe 20-30% of patients seem to show high alkaline phosphatase, and I was wondering why this could be happening. And then we planned a study and looked at this subset of patients. We cleaned some of the data, got into the groups which are clearly normal or clearly abnormal, alkaline phosphatase, not bone alkaline phosphatase, and then planned the study. And that's when we understood that actually this could be actually indirectly reflecting a cardiovascular risk rather than anything else, rather than a bone abnormality. The background of the study, therefore, when we looked up literature, was individuals living with type 2 diabetes, of course, are at risk of atherosclerosis. The pathogenesis of atherosclerosis includes calcification of atherosclerotic plaques, as we all know. ALP, particularly the bone alkaline phosphatase, is associated with vascular calcification in end-stage chronic kidney disease. That was a known fact. It was already known in literature. Elevated ALP has been associated with increased mortality in CAD. This has been reported. Unexplained elevations in serum alkaline phosphatase, perhaps bone alkaline phosphatase, occurs in diabetes mellitus, and therefore we explored the possibility that this could be associated with CV risk. Bone alkaline phosphatase actually is expressed in vascular smooth muscle cells also. And vascular smooth muscle cells release matrix vesicles which act as a nidus for vascular calcification. And some matrix bound vesicles have high concentrations of bone alkaline phosphatase. And therefore, bone alkaline phosphatase is believed to increase calcification in the vessels by several methods, including inactivating pyrophosphates, which inhibit calcification, inhibiting osteopontin, and also hydrolyzing organic phosphates, which release phosphates. And therefore, a change in phosphate to pyrophosphate ratio is what is thought to lead to excess calcification in the vessels. That is a hypothesis. When we looked at data, and as you all can see in this slide, whatever you can, except for the alkaline phosphatase and few lipid parameters, they're all matched for age, female sex, duration, the sex ratios, duration of diabetes, BMI, the glycemic parameters, and so on, and also the calcium phosphate and PTH profiles, more or less. And also the ABIs were similar, and yet you find two groups of patients who were carefully selected who had on the left low normal alkaline phosphatase, and the middle row significantly higher alkaline phosphatase. And then we looked at their bone alkaline phosphatase and few other parameters. What did we find? Significantly elevated bone alkaline phosphatase as expected, just showing that the elevations in alkaline phosphatase were actually coming from the bone. Their leptin levels were normal, which is also studied, and their vitamin K2. And mind you, vitamin K2, and I think there was a talk on vitamin K. I'm not in this conference. Also has something to do with atherosclerosis, and it is believed that vitamin K2 actually prevents vascular calcification. And therefore, in this study, when we looked at this group with high LPs, we found lower vitamin K2 levels in them. And there was good correlation between the bone alkaline phosphatase as well as vitamin K2 levels, inverse correlation, suggesting that the two, either one leading to the other or the two together, promotes vascular calcification in individuals with high ALP. And therefore concluded from this study that there is several, we concluded from that study that bone alkaline phosphatase could be the underlying factor which is causing unexplained alkaline phosphatase elevation in many of our patients, and to find that on the basis of that we could substratify our patients who are actually at elevated or increased cardiovascular risk. It may be a simple measure, could be a biomarker, and could just by looking at the alkaline phosphatase in those individuals you might focus your attention about preventive measures for cardiovascular disease. So what have I concluded? I mean, 3 or 4 aspects, but I focused on the most recent aspect, which is of course yet to be published. There are several facets of diabetes-related atherogenic risk which are being explored recently, which is beyond what we all traditionally understand, and which are contributing immensely to our understanding of what is driving this risk in type 2 diabetes. Because the traditional risk factors do not account for all the excess atherosclerotic risk in diabetes, all that we know. And therefore, there are several unknown areas, and some of them were highlighted in this talk. And some of this research can lead to the development of useful early biomarkers, simple as well as complex, to identify diabetic patients with a higher CV risk. With that, I conclude. Thank you.
Can I have one question? Thank you. So you spoke about the postprandial or non-fasting triglycerides. Is there a cutoff? When we start doing it, because of point of care testing today, a lot of us are doing non-fasting lipid profiles. But there is no real cutoff. How do
ये
you
सब निकाल के
differentiate that?
वो भाई का कौन था
The
हमारे भाई का
cutoff
कौन
in
सा
terms
होता था
of
मेरे को दे देना
as a diagnostic test,
हमारे भाई
we
से
are
कौन
doing
कौन
that
सा
at the
आया
moment.
था
But there is
एक तो एक
cutoff
है
used by the
ये दो
biomarkers to define
ये
atherosclerotic risk,
ये एक दो
particularly based on CIMT. That slide was there, was 200 milligram per deciliter, postprandial non-fasting.
हाँ तो वही
That
आपको कोई
cutoff is
दबाया हुआ है
associated with
केबल
a significant
वीजीए
excess
केबल
cardiovascular
ये
risk
सब
in diabetic patients. But we are in the process of
अरे
finalizing
हमारा
the
कौन सा है ये
diagnostic
पूछा
cutoff
मेरे को नहीं
based on
पता
our own studies. Now we have about 700-800
क्यों
such studies available to us. So we are working on that, and we'll probably come out with that
अरे
very
तो क्या
soon.
हुआ ये ले जाना पड़ेगा ऐसे लगा कर नहीं छोड़ सकते
We did the
ये सब भी ले
vitamin
जाना
D.
पड़ेगा
Now
ना
the PTH also was
लैपटॉप
done just to
निकालूंगा
see
फिर ये इसका क्या काम
whether elevations of PTH secondary to a hypovitaminosis D. That is also actually it was slightly lower in the group where there was higher glycosylates. We have explanations for that, but it was not due to that, due to vitamin D deficiency. Yeah.
ऑलमोस्ट सब जगह तो अभी खत्म हो जाएगा
Continuing with the Manoj's question on postprandial hypertriglyceridemia, the means that increasing TG is associated with increase in CV risk. I'm talking about primarily hypertriglyceridemia. In absence of low HDL, number one. Second, as he asked, there is no cutoff.
8:30 बजे तक आना पड़ेगा सुबह 8:30 बजे तक यहाँ आना पड़ेगा हाँ तो 8 बजे निकल जाना तो 8:30 बजे पहुँच जाना 8:30 बजे यहाँ पे आना है सब जगह पे अरे कल खाए ना 12 बजे तक दिए दोपहर को हाँ इसके लिए सुबह जल्दी आ जाओगे अपन 1 बजे में फ्री हो जाएंगे सब
I
खाना
deliberately
खाने का
spoke
टाइम
less about PPTG because usually I talk
कब
about that,
खत्म
and I thought I'll touch newer areas
ये
this
तो क्या
time.
आज
All three
दोपहर को
valid
चालू हुआ
questions.
2
The
बजे
first question is
तो ये 8 बजे तक
PPTG.
खींचा
I'm fully convinced
कल
that
सुबह का 8 बजे
postprandial
तक होगा तो ये 2
triglycerides
बजे
is
फ्री
an important cardiovascular risk marker. Why? I don't know whether some of you are aware of a study by Pat Chettel, who actually showed while we believe everything is low HDL, the fact
अरे
is that
भूख
the low
लगी है
HDL is a
खाना
consequence of a high DG.
थोड़ा बियर मिलेंगे
That's
बियर
the actual
पियेंगे
issue. So
बाहर में
in a large study, I think this was in the 90s, where cardiovascular risk was
बियर
studied,
पी खाना
particularly
खाने
was
सो जाने
studied, HDL was a very
सुबह
important
फटाफट आते
cardiovascular marker and the most important cardiovascular marker in the regression analysis.
इसके लिए ना
The moment
थकान
you
उतर जाती
added
है
PPTG, the HDL value in PPTG will go up. As long as you added fasting TG, HDL was the most important risk marker. And they were the first group to suggest actually that probably it's the postprandial TG, and they were looking at the fasting TGs, so we're not getting into the right thing. Once you start looking at postprandial TGs, then it will become far more important. And therefore that was around the 2000, late 1990s, when this was emerging as a good or important cardiovascular risk factor. And that's when we got on to it in Indian diabetic patients. The second question is regarding the cutoff. There are no data at the moment, I'm sure, and we are working on that, probably will come. The 200 cutoff is only from one study, which is a Japanese study, only based on a CIMT surrogate marker which was surveyed for CVD. It was not a long term or a study in humans where you could say that it is associated with future cardiovascular events or mortality. No such thing. It was just one study. I just mentioned because asking for a cutoff. It's not a cutoff in the true sense of the word based on longitudinal studies. That is the second thing.
Wanted to be very stringent.
No, and the third thing, that's where I'm coming. The third thing is
Eligible for a drug in that case.
TG risk or a PPTG risk as a risk factor of cardiovascular disease is not the same as if you control TG, will it reduce CV risk? They are two separate questions. We need to understand that. So just saying that excess TG or excess PPTG is associated with higher CV risk doesn't necessarily mean that by reducing the TG you are going to reduce the CV risk, and that is the problem. That's where the problem is. So that 200 cutoff, if you reduce it to below 200, will it reduce? That question is a different question altogether. That is not answered by these
That's
studies.
what I asked you, because in the 90s and in 2020, if you look back, all the trials which was primarily done to reduce TG or to increase SDL, all failed.
That's what.
So we did the meta-regression analysis to find out why it was happening. We look into any trial, starting from the failed to accord lipid to SPS2 thrive to aim high, all trials failed. Summarily, all the trial till date done to reduce TG has failed to show any cardiovascular protection.
Correct.
Now, if you analyze all those trials put together, the consensus came out that yes, the TG could be a severe risk factor in a background when there is associated decrease in SDL. Right? So there was one cutoff was made that okay, if you have got a TG of more than 250 milligram per DL or SDL is less than 25, these are the groups where you might get subset of patients by using fibrates or any other drug that lowers TG or increases DL might improve the CV outcome. So the entire, the 1990s theory of TG, I don't know how far we are at the moment in terms of cardiovascular risk, just based on a galvanic intima media thickness. There are a number of trials that reduces CIMT reduction with many drugs. All SU reduce CIMT, or none of the trials showed any positive outcome. If you remember, even DPP4 trials all suggested reduction in the CIMT, no reduction in the original trial. So CIMT is a very soft surrogate. We do not say, a lot of things unless the drug reduces the CIMT.
I fully agree with you. I'm totally open to that, and the fact is that reducing TG has not been shown to be associated with decrease in cardiovascular risk.
But I agree with you that primary TG, perhaps may have a little bit of different kind of CV resolution than the fasting TG. It is increasingly believed that those people who have got a primary hypertriglyceridemia that tends to produce more cardiovascular disease. So these are newer things.
In fact, the first 7-8 slides were more focused on that aspect, but I skipped those
But
slides.
unfortunately, everywhere in the world we do a fasting TG, right?
Yeah.
The Denmark is the only exception where they do a prandial TG.
Yeah.
It's the only country in the world.
Actually, postprandial TG and HDL, fasting HDL are very closely related. And the PPTG actually drives the HDL. This is also a theory, and a lot of metabolic pathways are there for that. And that's why people say that you focus more on reducing PPTG rather than fasting TG, you might have better results. So those trials are required.
So did you ever see any relation with the increased uric acid and the risk of CVD mortality in the diabetics?
We didn't study that aspect, but yes, there are some studies which have shown that uric acid is a factor, but we didn't look at that. We didn't look at those aspects.
In your study with alphos, did you do the isoenzymes or it was just the alkaline phosphates?
The alkaline phosphates, and then we looked at the bone alkaline phosphates, bone specific alkaline phosphates.
Thanks, Thank you.